This recording will go over transfusion therapy. Transfusion therapy is giving blood or blood components to treat things like anemia, bleeding, or clotting problems. This entire topic is about safety and reaction recognition. If you think something's going wrong during a transfusion, the priority is to stop the transfusion immediately. This isn't something that we want to wait and see if it gets worse. We want to act fast and figure out what the problem may be. Preparation is where you prevent errors. So before you give your blood transfusion, you want to be assessing your labs, H&H platelets, whatever it is that you're going to be replacing. You want to look at baseline vitals. You don't want to go and get the blood product and come back up and realize your patient has a temperature and the physician wants to address the temperature before the transfusion gets started. You want to look at the history of reactions and look at any meds that might be ordered between units of blood. So really plan out well, get a great set of baseline information for your patient, get a history of reactions, allergies, and plan out what the administration is going to look like. For IV access, the larger is better. So 20 gauge or larger is preferred, but 22 is acceptable. The big important thing is once you obtain the blood, you want to be ready to check it, do your second check with it, and get it rolling. So it's not like you get the blood from the lab and then you're going to get your set of baseline vitals and look at the patient's H&H. You're going to get all that so that you're ready to go as soon as you have that blood. You got the tubing ready. You just got to verify it, prime it, and get it going. Important things is that it requires a second verification. So you will verify in the lab and then at the patient's bedside with either another nurse, or some facilities allow for scanner verification as the second form. You're going to be comparing patient's identity, blood type compatibility, and the expiration date of the blood product. Important considerations for during transfusion. You're going to use a special filter tubing that is used for transfusions. This one is specific for packed red blood cells. So depending on what you're infusing, you might have different types of tubing. It's important that you only use normal saline with blood products, never lactated ringers or dextrose. The only type of fluid you would ever run with a blood product is normal saline. You're not going to give an IV push when a blood product is running, nothing at all but normal saline. It's important, very important, to stay with the patient for a minimum of 15 minutes once the administration of the blood product gets started, because that's when they're at highest risk for a reaction. So we want to catch it early, be with them, and be able to stop the infusion if needed. We want to monitor vital signs and signs of reaction continuously. It's going to be pretty frequently initially, and then as the patient demonstrates they can tolerate it, we can space those out a little bit. You will follow your facility policy regarding how long you're required to be in there when you start a transfusion, and how often vitals are needed to be assessed. After the transfusion is complete, when you stop the transfusion, you're going to dispose of the blood and blood tubing properly. Make sure you document thoroughly. If the patient should have a reaction, you will actually collect the remaining blood and the tubing and return that back to the lab. So that's something that you wouldn't dispose of, but it would be returned to the lab if there's a reaction. And of course, always double check your facility policy. So for packed red blood cells transfusions, there is a time limit. So it must be completed within 4 hours of initiation. Another important thing to assess, we talked about vitals and looking at labs, is to flush the IV site and make sure it's good before you go and grab your blood. Because again, when you take it from the lab, the timer starts going, you have 4 hours. And if you come back to your patient and their IV site is bad and you just realize it when you're getting ready to hook up their blood, now you might have to take time trying to get an IV started in someone who's at hard stick. And you could use up a half an hour of your 4 hours. So be aware of that. You got a 4-hour time limit. At 4 hours, you shut it off, even if the entire bag hasn't been infused. Another thing is this does require a special type of tubing that has a filter. A big thing to watch for in patients, especially older adults, is fluid overload. So watch for hypertension, bounding pulse, dyspnea, restlessness, because that fluid can actually cause fluid overload for the patient. Some patients will have prescriptions for diuretics in between units of blood, but think of the things that you would assess for your patient. So make sure you're listening to lung sounds before you start the infusion, getting the set of vitals, and monitoring them frequently during the transfusion. For blood compatibility, remember that O negative is the universal donor and AB positive is the universal recipient. If you're unsure in emergency what the patient's blood type is, we're going to be giving O negative because that's the universal donor that can be given to any recipient. And an Rh positive patient can receive Rh positive or Rh negative blood, but an Rh negative patient can only receive Rh negative blood. So here are some different types of blood products other than packed red blood cells that could be infused. They include platelets. Platelets require a fast infusion time of 15 to 30 minutes. There's no ABO match required for platelets, and they don't require that special tubing with a filter. Platelets are fragile, so they need to go in fast. They do require the special tubing, but it won't have the filter because the filter could harm those fragile platelets. So make sure you're using the right tubing, and it's going to be different from your packed red blood cell filter tubing. Another product is fresh frozen plasma. This one does require ABO compatibility, and you're going to infuse it over 30 to 60 minutes, and you can use straight filter tubing for that one. With granulocytes or white blood cells, you're going to infuse over 45 to 60 minutes, monitoring vital signs frequently, and we're going to avoid amphotericin B near transfusion time. Amphotericin B is avoided when granulocytes are being transfused because if they are administered simultaneously, it can cause a potentially fatal lung reaction. And just a reminder again, the tubing for platelets, it's actually a smaller filter than we use for the packed red blood cells and a shorter tubing. The platelet filters help remove white blood cells from platelets for patients who have a history of febrile reactions or who need multiple platelet transfusions. The standard blood administration set that we use for packed red blood cells is not used. It's longer tubing, and it increases the risk for platelets adherence along the lumen of the tubing, and that would reduce the amount of platelets the patient receives. If you suspect a transfusion reaction, the number one priority is to stop the transfusion. We want to keep the IV open with normal saline, notify the provider, and monitor vitals. Here, I actually updated the order for general rules when you're having a transfusion reaction. Definitely the priority is still stop the infusion, keep the IV open with normal saline, monitor the vitals, right? We focus on our patient, and then we're going to notify the provider. One reaction that can occur with blood product transfusions is acute hemolytic reaction. It is the most dangerous. It is the worst reaction you're going to see when the wrong type of blood product is given. So there's an incompatibility. One of the hallmark signs is the patient complaining of low back pain, which is actually kidney pain. Other signs include fever, chills, tachycardia, and shock. Again, priority thing we need to do is stop the transfusion immediately, get some normal saline running, monitor vitals, and notify the provider. Next up, we have allergic reactions and febrile non-hemolytic reactions. Allergic reactions, nothing new to you. The patient has a sensitivity to plasma proteins and they present with an allergic reaction, rash, itching, urticaria or hives, and it can progress to anaphylaxis and anaphylactic shock. Treatment would include, again, stopping the infusion, but also we could treat with antihistamines, epi, and oxygen. The other type of reaction is the febrile non-hemolytic reaction. This is due to antibodies to donor white blood cells. Patient can present with fever, chills, headache. There's no hemolysis with this one, and treatment would consist of acetaminophen, of course, after you have stopped the transfusion. Next, we have transfusion-associated circulatory overload and transfusion-associated transfusion-related acute lung injury is that last one there. So for the first one, transfusion-associated circulatory overload. That's basically signs and symptoms of fluid overload. You're already familiar with those: dyspnea, crackles, jugular vein distension, hypertension. For that, we're either going to slow or stop the transfusion. If we don't have diuretics on board, we're going to be given diuretics, elevate the head of the bed. Circulatory overload is not a new concept for you. The second one is a respiratory emergency. It's a lung injury. So in this instance, the donor antibodies are causing lung inflammation that can lead to severe respiratory distress. Treatment can include oxygen or possible ventilation, but just remember that there could be a lung reaction with certain blood products. Next up, we have transfusion-associated graft versus host disease. It's rare. It's when the donor T cells actually attack the host immune system. So even though it's rare, it's life-threatening. Things that we can see include weight loss, infection, liver issues. We can prevent this by using irradiated blood products. So blood products that have received a specific dose of radiation to destroy the ability of the donor white blood cells to reproduce. This slide produces a nice overview of the different reactions we talked about. Remember, if you suspect any reaction, you're going to want to stop the infusion and investigate. So acute hemolytic reaction, your patient will be complaining of back pain. If the patient is complaining of itching or hives, we're worried about an allergic reaction. Do they have a fever? Could be a febrile non-hemolytic reaction. Signs and symptoms of fluid overload you want to watch for. Any respiratory distress. And then watch for signs of graft versus host, including weight loss, infection, and liver issues. Important considerations. Stay with your patient initially when infusing new blood products. Whatever their policy says, a minimum of 15 minutes. Normal saline is the only fluid that is used with blood, never lactated ringers or dextrose. We're not giving medications with blood products. This is frequently tested. So normal saline is the only thing we'll see with blood. If we suspect a reaction, the first thing we're going to do is stop the transfusion. In terms of blood types, O negatives, the universal donor, AB positive, the universal recipient, and make sure you infuse your packed red blood cells within 4 hours. Here's another slide for you to glance at with some need to know information or reminders about important information. And again, another slide with some reminders, but all stuff we already talked about.